right, welcome back to the show. I'm honored to have our next guest. We have chiropractor and physiotherapist and strength and conditioning professional. We have Greg Lehman. Greg, welcome to the show.
Yeah, thanks for having me. Good to
So
be here.
this will be interesting because we could go down many different avenues to talk about. But really, I think, you're on a couple of podcasts. You have some courses out there. You teach Reconciling Biomechanics with Pain Science and running Resiliency. And so for those of you that are listening or maybe watching the show, could you explain to them kind of where you thought of the idea for your course? Because it's an interesting course. So I'd like for you to share a little bit of the background into the class.
Yeah, so it's been 7 years now that I've been teaching that. And I'd been teaching at the Chiropractic College and other places since the year 2000, believe it or not. When I went to Chiro College as a student, I had done a master's before, and they were really great and not roped me. I was happy to go in, and I was teaching in the grad program. So I've always been like this. Like the course is just about, it was once about really challenging what we did and then providing an alternative like that. That's how it started. And it's morphed to where I do a lot less myth busting now. And it's more providing an alternative. And like the way I view the course is we all have the same issues and problems as a clinician. And then this is one way to help you resolve those problems. And then what's really nice with the course is we get a nice group of people of 20 to 30 people. And then you get different viewpoints on how to, deal with the same issue. So that's what I love about the course now.
Yeah, I think
so how it started. It just started because I've always been a shithead, like challenging ideas, and people would say, well, what the hell are we supposed to do? And I was like, hey, figure it out. And then I was like, okay, I'm going to provide an alternative. That was it. I've been like always poking holes in things forever. And then I said, oh, okay, well, here's another model or another framework, without telling people exactly what to do. Because I believe in a big tent, like the details can be different. We can practice very differently, but we can all have common themes on what we do.
Right.
There's just different ways to apply those principles. So that's the thrust. That's how the course occurred.
Well, I love how you gave the background of a lot of the treatment models dating back to like, the 50s and the 60s in your course. And so you go through, the kinesiopathic model, you go through, all of these models for care that some people might anchor their treatment based off of this model. And you just share it informationally. You just go, here's the information, do with it what you want, but you should also learn to kind of ask these type of questions about the model. And you do a really good job of just asking probing questions. So when I came back from your class, I drove down to Tennessee for your class in Nashville, and I drove back up, and the whole way back, I was like, man, that was kind of a mind bender, because I was trained in X, and then now I'm thinking more along the lines of, and for an example, one thing that you said was that we're all trying to be, experts and masters of our craft. And it's like, we're all going up this clinical hill, and at the top, there's this fence, and we just think, well, once we make it, what do we do on the other side of the fence? And in so many words, you might be able to correct me how I'm kind of botching your quote, but you're like, there's nobody on the other side of the fence.
Oh, okay. I haven't used that one in a while. I know what that is. That's this idea, like we all think like that someone has special knowledge out there.
That's right.
Right. And they're on the other side of the fence. Right. And we got to go get that knowledge, and then you realize, no, there's no one over there. Like there comes a point in your clinical career where you've just hit the edge of what we know. And that's kind of frustrating and hard, but don't feel bad. And then that was sort of me ranting against continuing education, where you see some course advertising, like we have all the answers.
That's right.
And then you go to the course, like, bullshit. No, you're just like made people feel stupid, right? Like it's such a selling tactic to come to their course. And then you realize they have no clothes on. I just mixed my fence and emperor metaphor, but like, they're not really on the other side of the fence with anything. They're on the same side of the fence with you, and you're all in the same boat. So I acknowledge that we have a lot of uncertainty, but we can still do like really well as clinicians.
Yeah. And that's something that, full disclosure, I run a continuing education entity. And that's something that I'm very vigilant about. Even the slightest marketing or promotion it's more in line with what you just said about uncertainty. I'm totally cool with uncertainty. And so our marketing and our promotion that we put out for our classes, like I despise when I read those promotions that are like, take this, and this, and you will become X, Y, and Z. It's like that. If life were that simple, and I'm sure we could sit here and bash on a lot of CEU
Mhm.
classes that are out there. And by the way, they're the same. And what I've noticed, even in our own classes, they change yearly. I mean, the information comes out, and as does yours, which is kind of what I wanted to unpack a little bit. So you teach classes. You're a former researcher, right? Are you still participating in research?
What's nice now for the past while, I just get asked to be like the third author of a paper, or someone has an idea, or they hear an idea of mine and they want to implement it. So I do stuff like that. So, but I'm not in the lab anymore or
Okay.
anything like that. It's like, it's an actually a really easy role now, but I get to be involved with stuff. And I'm the
Okay.
proofreader.
There you go. So then you like I said, you also treat patients a couple days of the week, correct?
Yeah, yeah.
Awesome. So how's that set up? Is it more like just you're a one man show, one man operating? Like
Yeah, absolutely. Oh,
talk to me
it's
a
so
little bit about your practice.
so we moved, like we're in Toronto, but we moved to the inner suburbs, 20 minutes from downtown to get a bigger house. And I bought a place that had an old workshop, and
Nice.
I just put a gym and a clinic. I renovated it. It's so simple. Like I'm looking outside now and I laugh because my website says, there's no waiting room. The waiting room is your car outside. I will come out and meet you on the sidewalk, or
Yeah.
knock on your window if you're on your phone. Yeah, and then we walk back. It's so bare bones, but it's what I wanted.
And who are the
Like,
type of patients that realize, well, this guy could probably help me?
ah, that's what's weird. I'm pretty bad at marketing. It just kind of happens, online. And then, but I do have, and then I've been doing online stuff for years, even before, the virus. So,
So that was a
just
pretty easy
people right on.
transition to just be like, okay, we'll just do this remotely or digitally.
Yeah, because my website and the free book I have, a lot of people read that, which is nice because then they read my workbook, and they get an idea of what I might do in person, which makes it easier. Like I don't have, uh, as a therapist, especially as a chiro, people might come in and expect you to do something, and what they think a chiro does, and I don't really get much of that anymore. I get here, you just tell me, yeah. So it's easier that way.
Cool. So you mentioned your free book that you have online. Is that for patients to benefit from? Is that from clinicians? Who's that written ideally for?
It's for both. It's sort of, I call it's recovery strategy. It's like my pain science book, but trying to be as practical as possible. It's not a lot hardcore neuroscience of pain. It's like, what are the fundamentals that people need to know to help them with their recovery? So it's just part of a process.
Brilliant. And I'm sure, like, I can't help but think through the marketing side of it. How many people have downloaded that over the years?
So I only recorded that the first year. Like
Okay.
people had to put their email down, and it was like 25,000, and
Wow.
I think 22,000 of those were therapists.
Wow.
And yeah, and then I know it got. I'll have like big companies in the states, like health. What do you guys say? You have like health networks or health groups? I don't know, but they'll. Uh, like big teams, and they'll end up using it as their chronic pain program,
Okay.
which is kind of neat. Like
That's
they've used it, and that's their basis for a 10-week program. Like,
brilliant.
oh, that's really cool.
Did you
I
ever
don't
think
I
that
don't really keep track of that stuff, but every now and then.
yeah, I wondered if you ever, when you sat down to write it, did you think, man, there's going to be large organizations, possibly even healthcare
No,
corporations that are going to be using
that's
this?
it. Healthcare. No, it wasn't. It was sort of like, these are the things I always say to my patients. There's really nice resources out there, but I find them. It wasn't in my voice, so I just, there's a lot of jargon that I didn't like. So I'm like, I'm gonna try to write this, and it was just sort of to help clinicians. That was the idea, and maybe help patients who can't see certain clinicians, just to have resources. So
Right.
that's always nice when someone writes me out of the blue and like, you helped me so much, but it's, you really took my pain from an 8 to a 3 or something. None of that like that education doesn't cure anyone, but it
Right.
really
But
takes
it,
the edge off for a lot of people.
and
Yeah.
it's having an impact. And I think this is one reason why I've started writing a book, and I hope to finish it this year, because it's in essence a legacy as well. Like it will stand the test of time, even your time here on this earth. So it's interesting that will be around for many, many years to come. So that's pretty cool.
Yeah, hopefully. Like I've thought of that one now is, since it's almost 5 years old, and I still use it. I wouldn't change. Like the principles are still there. Like, does it need to be updated with research? I'm like, there's no research, but it's just kind of academic. It doesn't
Right.
change the fundamentals. Like I don't have the term plastic in it, but I don't care. Like, you know what I mean? That's like a new
Yeah.
term that we've
Yeah.
used for the types of pain, or and and I'm like, well, whatever. That's just, who cares? But I don't ever say the word plastic to my patients.
Yeah. Yeah.
I'm not a researcher. It's not going to help me. So like I'm off topic, but sometimes we feel like we're drowning in new evidence. And I
Yeah.
think you're just drowning in decorations. Like I was just described treatment as like a Christmas tree, right? The foundation is there, the branches and the whatever, I don't know, leaves. What do you call it when it's coniferous? The pines? I don't know. But anyways, like that's treatment. And then every now and then we just decorate the tree a little bit, right? And often that's just what's changing, is how we decorate, or how much tinsel you put on or you don't put tinsel. But it doesn't really change the fundamentals of the tree.
That's right. Oh man, I couldn't agree. That confirms my bias right there. Like I see all of these, do this soft tissue technique, or people,
Yeah,
create
yeah.
their own certain things. I'm like, but at the end of the day, and I would like to consider myself more principled based. Like if you can fulfill the principles, then more or less you can, and maybe I probably shouldn't use this word. You can predict the outcome if you kind of have a starting spot. And I think what people run into is, um, it's almost like a scatterbrained, like they aren't sure of themselves. So then they decide, I'm just going to throw this at the patient. I'm just going to put this
Yeah.
needle in. Or I'm going to do this soft tissue technique. I'm going to mobilize this joint. And did that work? Okay, great. I'm good. That treatment is good. That confirms it. And it to the patient, it's like, wow, this person, they fixed me. And to me,
Mm-hmm.
I'm like, but I care more about the clinical rationale to how you got there. And if you can't explain it, then like I personally would be like, well, then I don't know if you did a long-term benefit to this patient. You might have done a short-term, remedy, but I don't know if you've done something. And it's that kind of critical thinking that I've learned from people like you. So it's really interesting. Who kind of taught you the ropes on how to think through things critically, and then to learn to ask probing questions like that?
So honestly, like so when I started my master's in the late 90s, asking those questions, I was really lucky. Like I didn't have a lot of myths to debunk, because I had good people around me who challenged a lot of ideas initially. But personally, I've always really been good at asking questions. When I did my master's, my joke was like I was the dumbest student that they've ever had, but I always asked really good questions. So it's just been natural for me. Like, because I would ask questions to try to understand. Like I couldn't do the math, I couldn't do the engineering stuff, but I would try to like simplify a research paper to see why it was relevant. So it's just sort of, it wasn't something I had to learn, and I just built it up. Like I remember trying to create a course notes for an orthopedic class in chiro school, and I tried to create an algorithm of all the tests we had to learn. Right? If this test is positive, think this, and if
Right.
this is negative, think this, and if these are positive, then do this. And for so much of what the therapy all the time ended up being the same, no matter what the
Yeah.
test showed.
Yeah.
You know what I
Yeah.
mean?
Yep.
And I was just like, oh my God. Like it was just a realization. These tests don't change what you do. What are the principles here?
That's right.
Right. And so that type of clinical thinking like that's, I've been pretty lucky. That's just how my brain goes to simplify things. Because I
And
knew I couldn't remember all of the tests, and so I would almost look for a shortcut to like not have to learn them.
yeah, I noticed
Yeah.
at my chiro school, I noticed that a lot of our nutrition courses were taught by ND, so naturopathic doctors, and they would have been, okay, this person showed up with eczema, or this person showed, and then like you boil it down to, oh wow, like this is avoid gluten, avoid dairy, like the same
Yeah.
treatment. We're at the very end of it, and I like 3 or 4 weeks into it, I was like, okay, just put tea tree oil on anything, and I don't mean to make light of it, because that's kind of
I
but to your point, it was didn't matter what was at the top. At the very bottom of it was the same 3 to 5 things, and I was like, so then I noticed similar trends in neurology and rehab. I was
oh
like,
yeah.
oh, interesting. So yeah, it's funny that you came from an orthopedic perspective, and I see it from the rehab perspective. If someone comes in with a weak core, someone comes in with weak glutes, then we do, X, Y, and Z. And across the board, everyone's going to be doing glute bridges and some variation of, quadruped,
Yeah.
cat, camels. It's like, the exercise is really irrelevant at that point.
Well, so that's what's great. Or look at knee pain. Like our
Yeah.
recommendations for knee pain now, exercise wise, this. You do something at the knee, and then you're gonna do something somewhere else at the
Right.
hip, at the foot. And people think, oh, well, do they have to be weak at the hip to do hip exercises? I'm like, no. Well, I don't need the weakness or strength isn't an indicator to give a hip exercise for knee pain.
Right.
That's what's so cool. Everyone should just get it. And they're like, well, how do you decide what exercises? Well, this is where we get to be creative. You say, well, say you have a runner, well, why don't we choose exercises that help your running? Right. Or say you're going to go to the beach this summer in your new tight shorts. Well, why don't we choose exercises that build up your booty? Like, do you know what I mean? Like, you can have there's other reasons to choose an exercise, but
Right.
you already know that you're probably going to give hip and calf exercises for someone with knee pain.
Right.
And people are like, well, what about an orthotic? And this is the research that's so neat now on knee pain. It's like, who should try the orthotic? Everybody. How do you know it's the right thing? They felt better. There's no more, this is Mark Matthews' research. There's no more, like, you don't need a type of foot. You don't need a certain positive test. You just give it a try. That's it.
It's like,
so what's your assessment for the knee? They have knee pain. That's all I need to know. And it's not cancer. It's not, you know what I mean?
Yep.
It's not, I don't know. It's not coming from the spine. Okay, great.
Yeah.
Giddy up.
It's almost too simple that I think some people will reject it.
Yeah. And your patience. That's the risk with all of this.
So how do you, let's unpack that a little bit. Cause you're very intentional with your words. You're one of the people I've picked up on how our words matter and how our questions matter. So how you phrase it, and even your inflectuation with how would you word that to a patient that you want to give them a simple, I almost use the word fix. We want to give a simple solution to their knee pain. And I want you to try to like explain how the patient would perceive that. Does that make sense?
Yeah, I try to like almost pretend they're a clinician, and I say these are sort of the principles of helping someone with knee pain, is that we need to calm it down. It's pretty angry right now, and we need to build it back up. So like our challenge is, are there things we need to avoid, or are there things we need to start doing more of? Right. And then I say, this is what I'm kind of good at for calming things down. If it's a runner, I'll be like, you probably need to run less or more frequently. You probably need to decrease some of your speed sometimes, but we're going to build back into that, so like and then I say, so there's a bunch of options that we can do here. If I was doing more manual therapy, I'd be like, and we can do some of this manual therapy to calm it down. I don't do much of that anymore, but I'm not against it. It's just, I don't know why, it just happened in my career. I started doing less. So you're like, how do we calm things down? These are our options. What would you want to do? And then I'm like, these are the things we need to build you back up. And there's a bunch of ways that we can do that. Like, what equipment do you have at home? What are you willing to do? Do you want to work out 3 times a week, or is it easier for you to do 1 or 2 exercises every day? You know what I mean? Like, you can lay out the options and then you create the program. You're almost educating the person as a clinician, and then you guys work together.
Brilliant. I found myself coincidentally just doing that this week with someone virtually, just kind of saying, okay, what equipment do you have? How much time do you have? I can give you 2 to 3 things, but would you rather have 2 separate workouts for the week, or would you rather have 2 exercises that you can just nail out and get them done? And she was like, I'd rather just like, this works better for me. And she picked the latter option. And I was like, great, okay, here you go. And then I sent her those 2 drills that I felt would be best for her, and go figure, like, she does them every other day, as I kind of educated her on. But anyways, yeah, to your point, that's really a clever way of kind of like flanking them, right? Like, if you just tell them, like, you need to do this, like, the moment someone says the phrase "you need to" me, it's kind of going in one ear and out the other, and I'm like, yeah, okay. But yeah, it's fascinating. So,
although you can lose some people, I will admit, I think there are a subset of people who want to be told exactly what to do by the guru.
And I think you can pick up on their tone and their demeanor, right? Like, I got into this one time.
Sometimes I pick up too late.
Yeah.
It's the end of the session. I'm like, God, crap.
Yeah. Well, I'll share this with you, is that I had a very like successful business guy. He was a former college athlete, and now he's just kind of like he's just that type,
Yeah.
right?
Yeah.
And he calls in. I'm talking to him. He's like, how much are your rates? And I was like, we're not the cheapest. He's like, how much are your rates? He's just like to the point and everything. Finally, it got to the point where I was like, dude, he doesn't want to talk about what his issue is, and he doesn't want to talk about how I can help. He just wants to know the dollar amount, right? So I just like put it back on him, and I was like, how much do you want to pay? And I just said the exact same thing back to him, and he was like, well, average chiropractic visit is anywhere from 50 to 85. But you're pretty good. So I would imagine you'd be in the 120 to 150 range. And I was like, double it. and his response was like, okay, yeah, when are you free? So I just like matched his tone and his demeanor, and that like won him over. But he would be a part of that subset that you just said. And I just treated him the way that he was treating me. And a strange thing happened. Like he, for lack of a better phrase, he bought in. But
Oh, that's good to hear.
if I kind of,
Yeah.
I'm 300, he'd been like, he'd have been, all right, you must not be very good. You can't even confidently tell me, how much your rates are. And so that's just the interpersonal skills that I've picked up over the years. Just kind of meeting people where they're at and then speaking to
Yeah.
them. So anyways, you were saying just kind of the subset of people you kind of have to speak differently to.
Yeah, but I don't always, and I think I might like lose some people with this approach, which is very we're a team, and it's not that it's like, I don't know if self-directed is the right word, but they're leading and I'm just along with them. There's that coaching model.
Yeah. Well, I think there is value in being the guide in someone's pain journey, and
Yeah.
I'm big on not letting a patient leave thinking that like they need my soft tissue skills or they need my adjusting skills, because then they're just going to be
Yeah.
reliant and dependent. Every time they have a flare up or an episode of something, they're going to think, oh, I got to get back into the office. And really it's like, I understand where that mindset comes from, but that's not necessary for everyone.
Yeah.
So brilliant. So in addition to that, the other thing I wanted to talk about is podcasts and just all of the resources that you put out there. You mentioned your book, and you're also a co-host still, correct? If I'm not
Yeah.
mistaken,
Yeah.
still a
Yeah.
co-host on the NAF Physio podcast, still with
Yeah.
Adam Meakin. So talk to me a little bit about your experience in just kind of the planning, the prep that goes into, or do you guys just wing it? Does he just send you a paper and you're like, let's just?
Yeah, we do some winging. Like we both we're just sort of driven by the wind on that one. Whatever's interesting at the time.
Okay.
We'll do it. Like Adam just did a debate on the SI joint with Diane Lee, and he's going to repost on our podcast. But then we're going to do a deep dive into it next month to really look at the research.
Brilliant.
And explore it. So we kind of both have the same interests. We disagree on a lot of things, which is good. So yeah, we don't do too much because the thing with research, we're always doing research. Do you know what I mean? Like I'm
Right.
always reading papers. It's what I've always done. So to say that I'm not doing research isn't accurate. Just not doing anything super duper extra than normal.
Right.
Yeah.
Yeah, that's one thing. Going back to your course, just because you mentioned papers, not to spill the beans or anything on your class, but one of the incredible resources from your course was the access to the papers. Do you still do that? Do you still like give everyone access to the papers?
I do. I'm actually just cleaning it up now, because what I do now instead is I have my online course,
Right.
which is longer than the in-person course and has a different focus. There's more academic stuff in the online, because I don't want to do the academic stuff in person or the myth debunking,
Right.
or have like lecture at people. So everyone gets, if you take the in-person, you get access to the online one. So
Right.
that's kind of that's sort of the reference material. And then if I tell them about the depository of papers, and I can give access to people as well. I'm just trying to clean that up so I can give it to everyone, because it was a mess before. It had like lecture notes for 7 years.
Yeah. It was massive file.
Yeah, I know. I'm trying to just make it cleaner.
So
It's
you
funny
you
you bring
mentioned.
it up. I just started this weekend doing
Oh,
that.
did you?
Like the computer's running for 5 hours, uploading and downloading and stuff. I'm like, holy. Anyways.
Well, you mentioned a couple of times, and I forgot to ask it a minute ago. In regards to the myth busting that you brought to the courses, in your kind of prep and in your courses, what were probably maybe the top one or two that you enjoyed the myth busting, especially for the chiro profession?
Oh yeah. See, it's the ones I never do anymore. Like, because I'm just tired of it. I've been doing that for 20 years, and I go on
Yeah.
Instagram and I see these young people, 20, 30 somethings. I'm in my 40s, just saying this like as if it's new to them, saying these things I've been saying for 20 years. I'm just like, oh yeah, I've been there, got it. Like, yeah, we can't be specific. Fascia doesn't turn into knots. I know.
Yeah. Yeah. Yeah.
So now I'm like citing myself from 10 years ago on research papers. I'm like, no shit, you can't stretch the IT band. uh,
Yeah.
I don't know with the chiro stuff. The ones I mean, when I was in grad school, I was in grad school with Kim Ross and Dave Bereznik. I don't know if you remember those names. And they did a paper with Stu McGill. Like they did 3 fantastic papers on manual therapy that sometimes I go around and I just lecture those. If I get invited to a chiro conference, I'll give a half an hour talk just on those 3 research papers because I don't people know them enough. And that's like the skin fascia frictionless interface, the inability to be specific with lumbar manipulation, and then the atlas axis facet asymmetry, which is so cool. Like it's a motion palpation dig where even if you could feel asymmetries left to right in the cervical spine, um, you don't know if that's just asymmetrical bones. Like the bones are shaped differently. And their paper was just showing how the bones were shaped differently in most people. So like you might be palpating asymmetry, but it's actually nothing. You can't do anything about it.
Well, how did let's unpack that a little bit. How did they find out that? Like, what type of
So you
images did they
take
do?
you
Or
take the atlas axis out of people's spines, like they're actually cadavers.
oh
They
wow, okay,
put them in it. They put them in a jig, remove everything, and then you take a wire on each side and a force transducer, and you film it with very advanced optoelectronic devices, so you can see how it's rotating. So as soon as you have that, as soon as you can measure how much something moves and how much you're pulling on it, that gives you a stress strain curve, right? That you have. And so you pull it to the left and then you pull it to the right, and you would measure how much force, the slope of the curve going to the right and left. And they had like 6, I think they only had 6 samples. People were like, oh, it's a small sample rate, or sample size. But I'm like, no, that's all you need. You don't need a massive number. And like only 1 out of the 6 was symmetrical left to right. The rest would be
interesting.
like, you'd pull it 2 millimeters and it would start to resist. The slope would go up. Then you pull to the left and you pull 6 millimeters and it would start to resist. So it
So how
was
does that?
naturally asymmetrical.
I'm sure you know this. How does that translate? Because you mentioned it's a like a motion palpation dig. So how does that translate to what we're actually feeling with our hands when we're palpating the joints?
So the implication there is if you palpated all of those people, the clinician would conclude, oh, they can't move as well to the left as to the right. And they would think that it's a muscular or soft tissue or some sort of restriction in the motion. And then they'd want to manipulate that for that reason. But it'd be like, it's nothing to fix. It's just their bones. They don't have the ability to go any further. It's like my ankle joints are like this. I don't have a lot of dorsiflexion, so my squats are poor. Like I have to bend a lot at my hips forward. And if I go to stretch my calves, I don't really feel it in my calves. I feel it in the front. There's a pinching, like it's probably a bony, like there's a bony, I don't know, it's a block, but it's a bony block. Like I probably don't have the ability to get much more range of motion, or maybe it's an excuse because I'm lazy. But there's a potential that it's just my structure, just like with the hip. When people
Right.
have like an impingement, you're not going to get any more hip internal rotation. There's just nowhere to go. It's not something you can stretch out. So
Right.
that's the implication there. But what I love about it, this is where a lot of this research is kind of academic. I'm like, to manipulate the neck or do soft tissue or help manual therapy in the neck, I don't need someone to have a restriction. Their neck hurts. That's why you do it. It
Right.
doesn't matter.
Right.
I remember citing myself when I was a student because my master's is on spine manipulation for pain. And the clinician was like, Greg, what segment are you doing? L3, L4, what's the indication? And I'm like, they have low back pain. What's your reference? Lehman, 1999, fucker. Like, I was such a dick. He's like, get out of here. I remember he was awesome. Like, you're an asshole. I'm like, I know, an arrogant asshole. You gotta be specific. Uh, but we knew that then. Like, and I remember, don't you remember having chiro like teachers be like, they do the left side and then the right. I'm like, why did you do both sides? Because you're trying to like think you're being mechanical. They're like, what's good for the left is good for the right. You know, then they light everyone up.
Oh yeah,
The patients would love them.
I had an instructor. He still teaches, and he teaches also for motion palpation, and he said in essence the same thing. Like, we just spent 8, 9, 10 minutes learning to palpate, this particular part of the neck, and then we asked him, okay, well, what would you do? And he's like, well, I would adjust. And we're like, that side, both sides? Oh yeah, both. Like, but you just said they were restricted. Like, do you? And I'm trying to connect the dots here, and it just came out like it was second nature to him. And I don't even think he even realized that it was at kind of what's the right word? It was inconsistent, like was the incongruent between what he had just been teaching us. The other thing that I wanted to ask you about is this notion that, especially for spine pain, like you mentioned, low back pain. And I get this all the time from interns that come to our office, whether it's a chiro or a PT or even a high school intern that just kind of wants to learn more about the difference between chiro and PT and what chiros can do and PTs can do, that sort of thing. Is they almost always ask me why the speed of the adjustment matters. And so there's a couple of papers that talk about the speed for low back pain, but I thought I would ask you, maybe put you on the spot here, about lumbar spine adjusting and speed of the adjustment. Any biomechanical things that we need to know, or is it any reference that you know of that speed does matter?
I don't think it does. I know that at the chiro college here in Canada, they have these dummies that try to give you feedback on your speed and your force development. The problem is the gold standard is someone who's done it for 20 years. And don't get me wrong, I think they have great hands, but you haven't really validated the gold standard by saying the clinical efficacy is better, right? Or the any biomechanical changes are relevant or better. So no, and so my I don't have any research because I'm kind of out of date on it. I respect manual therapists, but all I see is people who are fantastic therapists who do things so differently. And that's just enough for me. It tells me like these things that we quibble about don't matter. Right. That's kind of what I see with the speed stuff. Like, I remember everyone trying to hit me hard in chiro school because you'd let people practice on you.
Oh yeah.
And I'd have these 15-year like gurus who thought they were so fantastic and fast. And I hated it sometimes. They would they'd just light you up, and I'd be like, shit, I can't see. Like, what did you do?
Well,
someone would be nice and gentle. Yeah.
I've got a pretty wicked thoracic scoliosis. And so my cervical spine has a little bit of a correction of the curve. So like if you see my x-ray, standing x-ray,
yeah,
maybe people don't really know this, but from the top of my cervical spine to my sacrum, I'm actually like fairly straight. It's a pretty perpendicular line to the ground, surprisingly. But I joke with patients all the time, but I'm wavy in between. And
yeah.
But what's interesting is when you palpate my neck, like I don't feel symmetrical right to left. And so someone will try to go to adjust me, and they're like, "Oh, let me try that again. Let me try that again." And they decide to go harder and faster, and I'm like, I gotta stop you. Like I don't think that's doing what you think it's doing. And also, I doubt you're gonna change a 33-year-old scoliotic curve. So, anyways, just thought I'd share that with you.
Yeah. No, I think that I knew the theory better 25 years ago. You're getting in under the reflex latency. That was sort of the idea. I thought reflexes are 60 milliseconds or something, or 180. I don't even remember. And you got to like sneak in your manipulation before that, whatever.
Yeah, it's been a minute for me as well. So I think there's been one paper that looked at the speed of lumbar spine. It really, I think, only looked at lumbar spine adjusting. And so I'll try to find it, and then I'll send it your way if that interests you.
Maybe. Drunk and bored. I don't
know. Yeah. So no, this is great. This is really good stuff. So yeah, you're very, very good online, very good presence on social media. I think you got like 35,000 followers on Twitter. I haven't checked it. I've been kind of hit and miss with Instagram lately. But where
Yeah.
can people learn more about you? Where can they find more information about your classes and just and then I'll have one last question for you, but just I would love for you to share where people can learn more about you.
Twitter's the best one to talk for me. I don't like Facebook anymore, except for like mini ramp and skateboarding. Uh, so Twitter, that's just Greg Lehman. My website is greglehman.ca. I actually like blogs. I know they're out of fashion, but I like to write blogs as like reference material because I still cite my blogs to patients. I cite other people's blogs. I'm like, go check out this blog. It's a
Yeah.
good way to get it out there. Instagram's okay for that stuff, but I'm kind of tired of it.
Yeah.
I think sometimes you need to do something long form and have references and do a deep dive. And I'm still a big fan of blogs. Instagram for me is just like my skateboarding and gymnastics, trampoline. I put every now and then I sneak some like clinical stuff in there, but I prefer to be more narcissistic, uh, I guess.
Well, I
So
think
those are the areas.
just really quickly, what you mentioned about blogs is that someone once told me that um, that patients or customers, for a better lack of a better word, they won't necessarily buy into what they see. So if they see a video of you doing something, but they will buy into something they read.
Oh,
And so
interesting.
if you have something that touches on their, again, for lack of a better word, their pain point, right? Knee pain, Achilles pain, and you have a particular blog on your views or your beliefs or your strategies for Achilles pain. Well, and you send it to them, like that's going to resonate way deeper with them than if you were to send them these top
Yeah.
three Achilles exercises, like do these. They're like, well, they could just be scattering that out to anyone. That's not speaking to me. But if you read
Yeah.
something and you're processing it, you're like, holy cow, Greg wrote this amazing knee pain blog and it sounds exactly like me. Then when I call you up, you're gonna be like, yeah, I'm that guy. I wrote that blog.
Yeah. No, I'm with you. I had this horrible stomach pain for months
Oh,
where I was
that's right.
super worried and fearful, thought it was cancer, and all those fears and worries and catastrophizing were making it worse. So I wrote this whole blog about it, and I got better once I had like imaging and all the testing. And then literally once I had all the imaging and testing and everything checked out and the biopsies, it went away within a week, or 3 days. It still bothers me every now and then, but there's no suffering. And I had so many people reach out to me and say how that actually helped their stomach pain,
Interesting.
or how it helped them with understand their low back pain or their hip pain or their neck pain.
Wow.
Right. So I love blogs for those stories. And I think like, if you believe in this sort of movement optimism message like this, like the more people that write these blogs, the more people will help.
I think
So I'm
it
going to keep
also,
writing them.
yeah, I think it's really encouraging to hear that because I've started to say, like I mentioned earlier, write a book, and then I'm kind of doing little teasers. Like the blog is
Yeah.
just going to be whatever people find really interesting. Well, great, that's going to be expanded on in the book. And what's interesting is you do have to kind of put yourself out there. Like you're kind of opening yourself up to professional criticism if you go against the norm for imaging, for example, like in your case in point, a lot of people would have said it's psychosomatic. You're just
Oh God.
it's all in your head, and that's like that could be quite deflating because you're the one that's suffering. Um, so share, if you don't mind, share a little bit about your journey on how you went from I have this uncomfortable stomach pain to I think I need an image, and did you know that it was going to come back
So,
clean, or what were your thoughts on that?
I didn't know. I was still worried. Like I actually increased my life insurance. Like
Wow.
it was real. I said goodbye to my wife. I set up a Tinder account for her, so she had some options of when I was gone or during while I was still here.
Oh man.
She's in the other room. You, you know, it was the same as low back pain. I didn't know what it was. And if we're going to treat people conservative with low back pain, you have to rule out sinister stuff. I'm always thinking that when someone has any type of pain, what's the worst thing it can be? Let's make sure it's not. Let's make sure this is something that I can help this person with. And so that's the process I went through with my stomach, because nothing made it better and nothing really made it worse. That's what concerned me. Like it wouldn't, I'd have like 6 beers. Let's see if that makes it worse. It wouldn't. I wouldn't eat. I'd have different types of food. I would try a different diet. I'd go for a run. Like I couldn't, that scared me. But, you know, like if you can't change the pain, like it didn't make sense. Pain didn't make sense.
Right.
Right. So that I'm like, I need imaging, you know, I got the ultrasound and then I got the scope and then medication didn't even touch it,
Wow.
you know? So, and I had stomach pain, still do, but this one was different as well. It wasn't my usual pain. So once you don't understand something, that's an issue. You have to understand your pain to make good decisions.
So how has going through that personal pain journey, how has that helped in your maybe compassion or empathy with people that are really
Well,
suffering with musculoskeletal aches and pains?
so I actually have had like kind of persistent pain since I was a teenager, you
Okay.
know, going to Cairo. So I've always been pretty empathetic, like, but I've been like, I'm pretty good at coping. Like I remember, you know, in Cairo school, I convinced myself I had ankylosing spondylitis, like 3 months of low back pain, so bad in the morning, responded dramatically to like anti-inflammatories, you know, limited mobility. I was run down, you know, so like I've had these things, you know, like it's always moving around. So kind of it helps in a way where I can empathize with people, but I'm still a bit of a successful story. It's that sort of living well with pain. But you have to watch that because you don't want to tell people like, "Oh, I did this, so you can do it too." It's
Right.
easy, you know.
Right.
That's you can you can almost make you a little nonchalant about it, where you're you don't want to be dismissive of someone else because you did well. So I just have to watch that. So I am empathetic, but it is nice. I think that's a nice message sometimes where we say to people, it's normal to have pain, and that surprises people.
Hmm.
But it also can kind of be a little like belittling,
Yeah.
you know, like you don't want to just here, you know, live with it. I'm not saying that, but I'm like, it's not fair to tell people you will be 100% out of pain, you know, 100% of the time.
Yeah, I think that finding that balance is really
Yeah.
key. And
And
when
hard.
it gets over to one side, it can be really tough to kind of get someone back over to the honestly, because sometimes they don't actually believe that they can ever be out of pain completely. So that would be
Mhm.
like really inappropriate to go, hey, and in these 3 visits, in your 3 to 5 minute appointments and these 3 visits, we're going to get you 100% out of pain. I would find that very inappropriate if someone's had persistent pain for months, years, decades.
Yeah.
You'd be like, you mean to tell me realistically that you can get someone 100% relief in 3 appointments? Like,
Yeah. Yeah. It's not fair. You set people up to fail.
yeah. And then
We're
people
supposed
wonder
to, sorry.
why, like, yeah, no, then people wonder why, well, I tried Cairo, it didn't work. I tried PT, it didn't work. It's like,
Yeah.
well, then maybe the clinician is culpable for what they said or how they framed it and how they presented their approach for you. So go ahead. You were
Totally. No, I was just going to say, when you see a lot of the patient advocates who are, you know, good voices on persistent pain and recovering well, they still have pain,
mm-hmm.
but they're living well. That's the old living well with pain idea, right? And that's why that's why I still like blogs, because I send people to their website, like Joletta Benton. Benton, I don't know, I've known her for years. I always say, is it Benton or Benton? God, sorry, Joletta. Her website's called My Cup of Joe.
Oh,
And then
that's
there's
right. That's
Bronnie
right.
Lennox Thompson, who's an OT and PhD on fibromyalgia, who has fibromyalgia. So there's like, and then there's this one woman out of the UK named Tina, and then there's Keith Meldrum, and these are all like patient advocates who are patients. They're all doing okay, but they all still have pain. They're just okay with it now, so they're living well with pain is the idea. So like,
Right.
but so often we're like, everyone thinks I have to be cured, and like that's not fair. And if you set yourself up to being cured, then you really think something's wrong.
Yeah, yeah, fascinating, fascinating. And do you deal with, going back to your patient base, do you deal mostly with the persistent or chronic pain patients, or do you get a whole mix of people?
I I'm awesome. I'm not. I'm my patient base. I'm super lucky, is what I meant. Like
Yeah.
I have such diversity. You know, like I'll see a, a runner who's trying to just almost made the Olympics for the marathon. You know, or someone who's just a high level athlete with persistent pain, and then I'll see someone who has persistent pain, is in trouble, and then I get a shoulder dislocation. It's all over the place, which is great. And people think, how okay, how do you specialize? I'm like, you specialize in like people. I don't know.
Yeah,
Like
that's right.
honestly,
Yeah,
the principles are the same. I've argued about the specialty idea, and I don't know. I mean, you specialize in orthopedic, I guess, MSK stuff. Like I'm not
right.
going to be able to treat neuro issues. I say I don't even know what to call those things.
Yeah,
Like,
yeah,
I'm not going into a hospital, with the acute care stuff. But the principles are the same for orthopedic MSK stuff to me.
yeah. Yeah, I definitely think that there's something, maybe the higher, I'm just kind of processing this out loud here. Maybe the higher the risk, the maybe the greater the need for some type of specialty. And I'm just picturing like orthopedic surgery, right? Like a general surgeon who does elbows, knees, hips, does that, it does everything, right?
Hmm.
Compared to someone who, just does, for some reason they always do like either knee and shoulder, or it's
Yeah.
they pair up a upper and a lower. Like there was one guy that I referred for a knee surgical consult, and he's like, oh yeah, I've done about 105 of these in my career. And he's like 15, 18 years into his career. And I was like, that doesn't seem like that much. And then
Yeah.
then the patient ended up getting referred on to, big medical teaching place in downtown Chicago. And that guy has done, I think, 5,000 of these procedures in his career. And I was like, I I think you should go to that guy.
Yeah.
So there maybe, and like I said, I'm just processing it, that maybe the higher the risk, like a surgical procedure, maybe the need for a specialty, but for the musculoskeletal treatment, I think you're
Yep.
right. I think we could have a broad scope in what we do, as long as it's like you mentioned, the principle based treatment.
At the high, I think the higher the need for specificity, where you might need a specialization,
Yeah.
right? Like that surgery, there's specific things that need to
Right.
occur. Like it's a higher need for one specific fix. But if you're working with athletes, like so, I don't know the snatch movement, but I don't need to. I can talk to them. Like if someone has pain with the snatch, the athlete is my resource. They're the expert on how to do the snatch, or their coach. So I'm not going to teach them how to do the snatch. I'll give them principles on how to work around their pain. If they want to keep snatching, I'll be like, well, what are the modifications we can make?
Right.
Right? If your back hurts with this extension position, okay, so and you need to get the weight over your head, what are the other things that we could do here to change your snatch technique? Or we don't touch it at all, and we're like, well, how do we calm shit down? How do we build you up to tolerate your snatch? You know what I
Right.
mean? I
Yep.
don't need to know the kinetics of the snatch, right? And
Right.
and I'd be like I've worked with some pretty elite, very elite weightlifters, and I'm like, you're the expert on your programming. Like, are you doing too much of one thing? What's going on? They showed me their programming, and then I just pretend like I can pretend like I'm an expert in it. But no, they will tell me their programming. I don't have to pretend I have fancy knowledge on programming for the strongest lifter in the world.
Right.
Like that's
Right.
just stupid. You
Yeah.
got to admit your ignorance, and then these are the principles. Let's work together to work around this. All right. Like everyone says, this specialization. I'm like, you can't be a specialist in everything.
Right.
Can't just treat the strongest snatch lifter in the world, and that's the only people you see.
Yeah.
You only see 3 patients a year.
I was gonna say, yeah, I definitely see like the marketing side where you have your, like, everyone's big on like an avatar, right? Like who's your perfect patient, and you can get really, really like into sub niches. It's like, I treat 40-year-old women that want to qualify for the Chicago Marathon. Wow.
Yeah,
Okay. All right. Well, then every year
me too.
you'll have, you'll have, you'll have, I don't know. I'm totally just guessing here, but you might have.
That is like a bit of a niche of mine.
Is it really?
But
That's
anyways,
hilarious. That's
I see
hilarious.
lots of that. Yeah, yeah.
Yeah, but that's oh, and I don't know if I even just said it, but like, and they have knee pain. It's like you could pick the person, the thing that they're trying to accomplish, and the body part that hurts, right? So like, I think there is value in
Yeah.
putting that out there. What I kind of cringe at is the is like where the practice is built on one thing, because the worst number in business is one. So if you just have one type of
Yeah.
person coming in the door, it's like
Oh yeah.
that's because if that goes away, it could just go away tomorrow, right? If some
Yep.
contract doesn't get renewed, like there or whatever,
Yep.
um, like that's your business. That's just gone. So, um, brilliant, brilliant. I got one final thing for you, which is just kind of the future. Like, where do you see Greg Lehman heading in 2022 and beyond? How many feathers is he going to ruffle? how many, no, I'm just kidding. But where does he see kind
Less
of
of
the,
that.
where do you kind of see your courses? Where do you see your blogs? Kind of what kind of messages do you kind of see getting either updated?
Um, I, so the two things I'm working on now is I'm putting my running course online, and that uh, and that's volume. Like I want to actually like I want it to be excellent, but I don't want to charge a lot. But I want to see it like spread throughout the world.
Yeah. So
Because
what, let me
yeah,
ask you this, business wise, okay? Because a lot of people have the capacity to put their topics into a Kajabi or into a Teachable and then put it online for
yeah.
the world to see. What's a goal that you have? Like, do you have a number and how many people you want to take your course?
So this one, like, uh, this is almost like a, not a, thank you sounds too, it's, I want it to be like only $200,
Okay.
which is pretty unusual for in that space. It's just sort of like, uh, I just want to spread it out. Like the reason I wouldn't charge less is only because I don't want people to think that it's useless. That when
Right.
you charge too little, but it's going to be really good. And I see other people charging 500-600, and I'm like, I don't need to do that. I'd rather have like a lot of people want to get it, and then I'll even do discounts and all that stuff. I just want to spread it. I want this information out there because I think running. I've treated runners forever, and I love the biomechanics, but I think that space is so overcomplicated, and I want to show it's the same thing. It's just simple principles, and you too can be an expert in running injuries, and there's not, the expertise is a lot simpler than you think, and that's the idea. That's purely like, I just want to spread
Yeah.
like that idea. It's maybe, yeah, I haven't really thought too much about this, like what I'm trying to achieve from that, but I think I just want to like just get the information out there. So I don't want cost to be a barrier for most people. So that's sort of the idea.
Yeah. Brilliant. I took a concussion class and it was just loads of information. I was working with the school at the time, and so I wanted to
Yeah.
be well equipped. And it was $1,000. It was a lengthy online course, but it was $1,000. And so that's definitely a barrier to entry is the price. But also when I signed up for it, I was paying attention to every single slide because I thought, wow, I just dropped a lot of money on this class. I want to make sure that I get the, so I see where you're coming from that like
Yeah. It's why I don't want to make it $50,
yeah,
but
exactly. Yeah. Yeah. Yeah, and what do they say? Like when people pay, they pay attention. So I think that there's some truth to that, but also I see where you're coming from in that like this message is good. We got to get it out to, and not everybody wanted to learn concussion, but in this case, a lot of people do treat runners, so it'd be really beneficial for physical therapists, chiros, even strength coaches, right? Like it's
so strength coaches,
yeah,
personal trainers, kinesiologists, exercise phys, running coaches, even
yeah,
runners. Like if it's $200, that's like a session sometimes,
yeah, yeah,
that's sort of the idea. Like, I think, I don't know. I don't mind making people who sell running courses a little pissed off at me, but we
yeah,
all say the same thing. And I'm like, yeah. What's neat now in that, especially in that space, I feel really vindicated in that space because I've been a critique of like proper running technique for decades. And now you're seeing the shift. Like a lot of people are getting on board with that. And, anyways, I won't being arrogant.
that could be, I mean, that could be an entire episode itself is
Yeah.
just all about running. So is it mainly for endurance runners? So I mean, just to clarify the difference between
Yeah, yeah. Not
sprinters and it,
sprinters. No,
so
no, no, no.
yeah,
I don't know
very
shit about sprinting. Yeah.
okay, that's good to
That
know.
actually is an area where I think specialization in terms of technique, yeah, I'll respect some of that.
Yeah, yeah, very cool, very cool. Yeah, I just thought I would clarify that because that course definitely would have some different material, sprinting absolutely a different animal compared to endurance running. So very cool. That's really awesome to hear about just the online programs and so you have the two classes will be online. And then what about your in-person courses? Are you still traveling the world? I mean, now that the world's kind of opening
Yeah.
back up again, it seems like what are your travel plans have in store here for 2022?
So I'm in the States a lot. Like 2 weeks from now, I'm in Lancaster, Ohio, and I stay down in the States and head over to Virginia.
Okay.
somewhere at Shenandoah University. Is that the,
Yeah. Yeah.
yeah,
I'm pretty sure that's in
I don't know. That
Virginia. Yeah.
one's,
Yeah.
yeah, it's in Virginia. And then I'm in Chicago in April.
All
I'm
right.
in at Gaylord. That's in New Haven. I'm in Montana at Bosman, Montana in end of March, I think.
Nice.
Then I head right over to Oslo in Norway and France and Italy. So I'm in Norway like 3 times in the spring,
Is
early summer.
Norway the country that they have a lot of naprapats? I remember you describing one
Yeah,
time
yeah,
that that's Norway, right?
yeah. They're actually, yeah, they're awesome because it's a small profession, so there's not a lot of inertia, and it's a profession that can stay really up to date,
So what
and
is
they
a
move and pivot with
naprapath?
school.
What is a naprapath?
They're us. They're just
Yeah.
us.
Yeah.
They're
Yeah.
like actually the founder. I think he was from Chicago.
Crazy.
Like, yeah, some American, and then he just went to Scandinavia, and yeah, they're really neat. Like there might only be 600 of them, or probably more now, but yeah, that's kind of cool. Like, 100 years ago, there was the chiro, osteo, and napropath in the States, and napropath he just took off and got out
It's
of the
crazy.
States.
I remember learning about it in school
Yeah.
and then it just disappeared, right? And then I've seen
Yep.
other things pop up like osteopractic and I'm like, wait a minute, what
Oh
how
yeah.
are these things? So anyways, all right, Greg. Um, yeah, so people can find more about you at greglehman.ca, correct?
Yeah.
Awesome. Awesome. Any closing thoughts, comments, complaints, inquiries? No, I'm just kidding. But any closing remarks you got for our viewers?
No, none. No, just hit me up on Twitter if you want to talk.
Yeah, and I definitely would advise everyone watching or listening to the show to follow him on Twitter, ask some questions of him on Twitter, and then also go to his website and download the resource guide that we mentioned. We might even
Oh yeah, the
include it
book.
in our show notes. We might even just
Sure.
email that out. Greg Lehman,
And
it's
that's in
truly
lots of languages too, because I
fantastic.
put that out there for free. Like if people would email me and ask for the InDesign file, and so
Okay,
it's been translated to maybe 10 or 12 different
brilliant,
languages.
brilliant.
Yeah,
Well, we
I'm proud
will
of that.
when we kind of when we launch this episode and we share it on YouTube and all the different platforms that our episodes go up on, we'll make sure we include the latest file that we have, and then if anyone needs it, we will make sure to send them to your website to download. Awesome, awesome, brilliant, Greg. Thank you so much for your time this morning.
Thank you.
It's been fantastic. I love kind of getting to know people, and I've said this on every episode. It's purely selfish, right? I get to interview these people, and I get to learn, a couple things about them, how they run their business, how their day to day operates. So I truly, truly am grateful for you taking time out, sitting with me here
Oh, my
on a
pleasure.
nice Friday morning. Greg Lehman, everyone, thank you so much for joining the show, Greg.
Thank you.